Hello everybody, welcome to my YouTube channel The Cowardly Doctor. In this video we are gonna discuss about the thyroid gland. We will discuss the chapter 15 of the endocrine pathology. So let's start the video. Before watching the video, please like and subscribe my YouTube channel. So let's start with the disorders of the thyroid gland. The first disorder which we will discuss today is the thyroglossal duct cyst. So let us first discuss some basic concepts. We know that the thyroid develops at the base of the tongue and then it travels along the thyroglossal duct due to the anterior neck. Normally the thyroglossal duct involutes, but sometimes due to persistent duct it can undergo cystic dilation, and this cystic dilation causes the disorder of thyroglossal duct cyst. So what is thyroglossal duct cyst? Basically it is the cystic dilation of the thyroglossal duct, and the important high yield point which we need to know is that it is present as a anterior neck mass. This is important high yield point. Here we can see a thyroglossal duct cyst. Here we can see thyroid, which is at the base of the tongue. Now we will discuss the second disorder, which is the lingual thyroid. This lingual thyroid is a ectopic thyroid. Now what does ectopic thyroid means? The ectopic thyroid means that any thyroid tissue which is not located at the usual position. Here we can see the lingual thyroid. It is present at the base of tongue mass. Here we can see the base of the tongue mass, and it is the persistence of the thyroid tissue at the base of the tongue. Now we will discuss the main topic of today, which is the hyperthyroidism. So what will happen in the hyperthyroidism? First of all, the level of thyroid hormone, which is the main hormone of the thyroid, it increases. Now there are two main things which we will notice. First of all, in the hyperthyroidism there will be increased basal metabolic rate, and there will be increased sympathetic nervous system. These are the key points of the hyperthyroidism. Also the important high yield points are that why the basal metabolic rate will increase. It will be increased due to the synthesis of sodium potassium ATPase, whereas the sympathetic nervous system will increase due to the beta 1 adrenergic receptors. So now we will discuss the clinical features of the hyperthyroidism. There will be weight loss, there will be sweating, as well as the heat intolerance. Why? Because the body basal metabolic rate will be very high, the sympathetic nervous system will be very high, also the body will break down the ATP very much faster. So in case of hyperthyroidism there will be tachycardia. In case of hypothyroidism there will be bradycardia. So there will be arrhythmia, especially in the elder people. There can be tremors, anxiety, insomnia. There can be staring gaze with the dead leg. Also we can see diarrhea, we can see oligomenorrhea, which is the abnormal menstruation. We can see bone resorption with hypercalcemia. We can see decreased muscle mass with some sort of weakness. We can see hypocholesteremia as well as the hyperglycemia. Now the important point, the main clinical features are these two. These are very important high yield points. Now the hypocholesteremia as well as the hyperglycemia, these are due to the increased gluconeogenesis as well as the glycogenolysis. Now we will discuss the main disease of the hyperthyroidism, which is the Graves' disease. It occurs due to the hyperthyroidism. So this disease is an autoimmune disease. It occurs due to the overactive thyroid. Overactive thyroid means that the body is producing too much thyroid hormone. So what will happen is that in this disease there is malfunction with the body immune system. Let us talk about the type 2 hypersensitivity. There is autoimmune body known as immunoglobulin G. What it will do is that it will stimulate the TSH receptor. Here it is a TSH receptor. Due to the stimulation of the TSH receptor, there would be increased synthesis and release of the thyroid hormone. It is the most common cause of the hyperthyroidism, this Graves' disease, and it important high yield point is that it occurs in the woman, mostly occurs in the woman of childbearing age, which are 20 to 40 years. Now we will discuss the clinical features of the Graves' disease. The first clinical feature is the hyperthyroidism, in which the thyroid hormone increases too much. The second clinical feature is the diffuse goiter. Now what is diffuse goiter? Whenever we hear the term goiter means that the thyroid is enlarged. Now how it is caused? It is caused when the TSH stimulation leads to the hyperplasia as well as the hypertrophy of the thyroid. So in the diffuse goiter there is hyperplasia as well as hypertrophy of the thyroid. And the third main point is the exophthalmos as well as the pretibial myxedema. So now we will discuss about the exophthalmos as well as the pretibial myxedema. So the main point first of all which we will need to know is that it does not occur due to the hyperthyroidism. It does not occur due to the thyroid hormone. It occurs due to antibody. So what will this antibody do? Let's say this is antibody. Now this antibody will stimulate the TSH receptor. When this TSH receptor is stimulated or we can say activated, what will happen is that there will be secretion of excess glycose aminoglycans. Due to excess glycose aminoglycans, there are fibroblasts that have TSH receptors. Now these fibroblasts are located behind the eye. So what will happen in the exophthalmos is that the eyes get popped out. Why? Due to the accumulation of glycose aminoglycans. So what will happen due to this TSH activation, which is done by the antibody? Now we will see inflammation, we will see fibrosis, we will see edema. So in pretibial myxedema, it is not due to the accumulation of water. It is different from normal edema because there is no accumulation of water, but there is accumulation of glycose aminoglycans. Due to the accumulation of glycose aminoglycans, there will be a dough-like appearance. Now in this figure, we can see a Graves' disease. We can see goiter, which is the enlarged thyroid. Here, this is goiter, it is diffusely enlarged. Here we can see a histological diagram, and this histological diagram, these are irregular follicles. Here we can see the hyperplasia. The follicles are very enlarged. Now one important thing which we will discuss is here we can see a normal follicle. It is pink totally, and we can't see any clear white spaces, whereas in this irregular follicle we can see some white spaces here. Now these white spaces, these are abnormal, and due to these white spaces it is known as scalloping of colloid. So now we will discuss the laboratory findings of the Graves' disease. So what will happen in the Graves' disease? Now first of all, the T4 will increase. If the T4 will increase, what will happen is that the TSH, it will decrease. Now let us recall our previous concept. Let's say this is anterior pituitary. The anterior pituitary will secrete TSH hormone. Now this TSH hormone is only secreted in response to TRH. This TRH is thyroid releasing hormone. So what will happen is that this T4, here TRH receptors are present. This T4 will downregulate this TRH receptors. So if there will be no TRH receptors, there will be no secretion of TSH hormone. Point 2 is the hypocholesterolemia, and the third is the increased serum glucose. These points we have already discussed. Now we will discuss the treatment of the Graves' disease. The first treatment would be the beta blockers. What the beta blockers do will they will block or inhibit the sympathetic nervous system. The second treatment includes the thioamide. What is thioamide? Thioamide is basically a drug that blocks peroxidase. So let us recall some basic concepts. For example, let us consider this is a follicular cell of thyroid. This follicular cell of thyroid will take in tyrosine. This tyrosine is converted to thyroglobulin. This thyroglobulin, it moves out into the follicular lumen. In this follicular lumen, the colloid will be present. At the same time, let's say this is iodide. This iodide is present in the blood. It will enter the follicular cell. It will cross the follicular cell and enter the follicular lumen also. And this iodide will do oxidation. And it is converted to I2. Secondly, we have organification. What will happen in organification? In organification, the thyroglobulin, it is added with the I2, and it results in thyroglobulin with monoiodide tyrosine as well as the diiodotyrosine. Now if monoiodide plus the diiodotyrosine, they will add, then they will form the thyroglobulin T3. But if, let's say, this diiodo combines with diiodo, then it will form the thyroglobulin T4. So what is happening is that if this peroxidase is blocked, then there will be no oxidation, there will be no organification, and it will block the thyroid hormone. Third, we have the radioiodine ablation. This radioiodine ablation, it will also destroy the follicular cell of thyroid, and as a result, there will be no thyroid hormone production. Now we will discuss the thyroid storm. What is thyroid storm? In the thyroid storm, there will be elevated catecholamines as well as the massive hormone of thyroid release in response to stress. For example, we can say surgery or childbirth. Secondly, it may be present as arrhythmia, hyperthermia, or vomiting with some hypovolemic shock. The treatment includes the PTU, the beta blockers, and the steroids. So what is a PTU? This PTU is known as propyl thiouracil. What it will do is that it will block the peroxidase. As we studied earlier, that if the peroxidase is blocked, then there will be no oxidation, there will be no organification, there will be no coupling steps of the thyroid hormone. So also the PTU inhibits the conversion of the T4 into T3. This T4 is the main hormone which is released by the thyroid hormone, and this T3 is more active form. Lastly, we are going to discuss about the multinodular goiter. What is a multinodular goiter? Basically, in this multinodular goiter, there are multiple nodules in a large thyroid gland. It is caused due to relative iodine deficiency. We have a term known as, usually the multinodular goiter, it is non-toxic, but sometimes it becomes toxic, and it is known as toxic goiter. So what will happen in this toxic goiter is that it becomes independent to the TSH, and there is continuous T4 release. Here we can see a multinodular goiter with multiple nodules. Thank you for watching the video. Please like and subscribe my YouTube channel.